Chapter 14, Medication Safety and Error Prevention. We have the terms and definitions at the beginning of the chapter. We will talk about those as we progress through this lecture and this chapter. So, drug errors are unacceptable in any situation involving medical treatment or medications. But the reality is that they will never disappear, no matter what we do. It is a human trait to make mistakes. Errors at times are not realized before they cause harm. And it's important to note that all errors are not harmful, that are caused by the pharmacy. So in this chapter, we will discuss drug errors, the types and incidents of errors, specific cases that unfortunately caused harm are presented in this chapter as well. As pharmacy technicians, we're at the forefront in the effort to prevent drug errors. It's very easy to make a mistake. Pharmacists make mistakes, just like pharmacy technicians make mistakes, especially if you're really busy and you're just trying to make it through the day, take care of all the patients. Things can get a little chaotic sometimes, and anybody can make a mistake. So there has been several times in my career where I have caught a mistake for a pharmacist. Does that make that pharmacist a bad pharmacist? Absolutely not. They are just stressed out. Something happened. They were probably pulled in a bunch of different directions. And as we just said, humans make mistakes. We're going to make mistakes. So I obviously would just go to the pharmacist and be like, hey, blah, 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 and just kind of explain to them. I would never make them feel like, oh, you made this mistake, whatever, whatever. And hopefully they would have that same respect for us when we make mistakes. And of course, when we first start out as pharmacy technicians, everybody in the pharmacy should be watching and being that triple check to prevent errors from happening when you're training someone. So someday you won't be new and you'll be training someone, and you'll just have to kind of keep an extra eye out because it's hard in the beginning. A study published in the Journal of Patient Safety in 2013 estimated that 210,000 to more than 400,000 patients per year suffer some type of preventable adverse event while in the hospital that contributes to their death. This was a much higher estimate than the estimate in a 1999 study completed by the IOM, the Institute of Medicine. The higher estimate was developed by John T. James, a toxicologist at NASA Space Center. He became involved in patient safety issues after his 19-year-old son died as a result of insufficient hospital care. The Institute for Safe Medication Practice, the ISMP, estimates that about 7,000 deaths per year are linked to actual medication errors. So that's a pretty significant number if you think about it. High alert medications are drugs with a heightened risk of causing significant patient harm when used in error. According to the ISMP, some medications considered highest alert in connection with errors are insulin, narcotics and opiates, methotrexate, warfarin, and potassium chloride injections. So box 14.1 lists the high alert medications in acute care settings. So besides the ones that were previously mentioned, we have opium tincture, promethazine IV, epinephrine, magnesium sulfate, and a few other ones. Community and ambulatory healthcare settings, these are some high alert medications. that you'll see in those settings. So you can see that methotrexate used in non-cancer use. Warfarin, those are still on there. We have heparin, that's a big one. That also includes unfractioned and low molecular weight heparin, the medication metformin, carbamazepine, chloral hydrate, midazolam liquid, propylthiouracil, which we commonly refer to as PPU. That is on there. We have the 5 rights of medication safety. The 5 basic rights involving medication safety. Healthcare professionals are expected to adhere to these guidelines to avoid medication errors. Number 1, the right patients. Always make certain the patient identification information is correct. The right medication, verify that the medication is exactly what the physician ordered. Is it brand or generic? Number 3, the right dose. Verify how many doses or tablets are to be taken per day, and how long is the patient to continue on the medication. The right route, should it be swallowed or chewed? Can it be crushed or broken in half? Is it for injection or to be taken orally? The right time, what time of day should the medication be taken? Is it taken after or before meals? Is it given at bedtime? An error is any type of preventable event that may cause or lead to inappropriate medication use or patient harms. Patients themselves cause many drug errors when taking their medications at home. They may take their medications at the wrong time, in the wrong amount, wrong combination, or with an improper administration technique. It's difficult to know how drug errors occur at home because they are typically not reported to anyone and may continue to occur unless recognized by a physician, a pharmacist, or worse, an adverse drug event or reaction. An error can involve prescriptions or OTC medications and can be committed by both experienced and inexperienced staff. The American Society of Health System Pharmacists, the ASHP, and the National Coordinating Council for Medication Error Reporting and Prevention, the NCC-MERP, frequently referred to as MERP, outline the most common types of errors that may occur. Types of medication errors are listed in this table. Compliance error. The patient does not adhere to prescribed medication regimen. So they could be taking the wrong dose, not taking it correctly, missing doses, and so on and so forth. Deteriorated drug error. Medication is administered that has expired or the integrity of ingredients has been compromised, like storing in a drug at room temperature when it should be refrigerated, or leaving it in your car when it's 90 degrees out, something like that. Improper dose error. The patient administered a dose that is greater or less than prescribed. Monitoring error. Failure to review a prescribed medication for proper regimen, appropriateness, detection of problems in dosage, or failure in using lab results to correctly adjust dose. Omission error. Failure to administer an ordered dose to a patient before next dose is due without an apparent reason for omission or appropriate documentation. So that's like when the nurse forgets to give a dose to the patient. Prescribing errors. Prescriber orders a medication that is incorrect. Incorrect usage, dosage form, route, concentration, rate of infusion, or is selected incorrectly based on indications or contraindications like allergies or existing conditions, and the medication reaches the patient. Unauthorized drug errors. Medication administered to a patient from an unauthorized prescriber. physician not listed in that state or not an authorized prescriber. Wrong administration, drug is given using wrong procedure or technique. Wrong dosage form, medication administered in a dosage form other than what was ordered. Wrong drug preparation, drug is incorrectly formulated or manipulated and medication is then administered to patient. Wrong time error, medication administered outside the scheduled time frame. If the facility allows plus or minus 30 minutes, dose is given outside of this variant. Medication error in reporting and prevention categories. Category A, circumstances that have potential for causing errors. The type of resulting error is no error. B, error occurred but did not reach the patient. So that is an error with no harm. C, error reached the patient but did not cause harm. Error, no harm resulting. D, error reached patient did not cause harm but needed monitoring or intervention to prove no harm resulted. Again, error, no harm. E, the error occurred that may have contributed or resulted in temporary harm to the patient and the patient required intervention. Error, harm. F, the error occurred that may have contributed to or resulted in temporary harm to the patient and resulted in monitoring or hospitalization. Error, harm. Category G, error occurred that may have contributed to or resulted in temporary or permanent harm to the patient. Error, harm. Category H, error occurred that may have contributed to or resulted in harm to the patient and required hospitalization to sustain life. Error, harm. Finally, I, an error occurred that may have contributed to or resulted in a patient's death. Error, death. Examples of prescribing errors include incorrect strength of a medication, quantity and refill information omitted, route of administration not specified, and illegible handwriting. Medication errors can be broken down into three main categories: prescribing errors, so the doctor; dispensing errors, the pharmacist or pharmacy, sorry, not just the pharmacist; and administration errors, i.e. the patient or nursing staff, whatever. Dispensing errors can be incorrect prescription interpretation, incorrect calculations, and incorrect drug utilization evaluations. Sound alike or look like drug errors may include the following: incorrect prescription interpretation, incorrect calculations, and incorrect drug utilization evaluation. Examples of administration errors may include the following: ear medications being placed in the eye, oral medications given intravenously, intravenous syringes used to measure oral medications, failure to document medication administration records accurately. Physician's handwriting has long been known for its illegible. Physician's handwriting has long been an issue, which means that reading drug names, strengths, and dosages can be very problematic. A alternative to the handwritten prescription is a new technology called e-prescribing. So that is going to be the gist of the prescriptions that you're going to receive in the retail setting now. Most prescribers just send the medication right to the pharmacy during your appointment, or if you call for a refill, they just send it. So you're not responsible for picking up a paper or getting a paper prescription and then dropping it off and then having to come back and get it. So it's kind of a great technology It takes away the bad handwriting. It speeds up the process to an extent and definitely helps the pharmacy run a little bit more smoother. So these scenarios you can read through have examples that show the possible progression of an ultimate drug error. These case studies for responsibility of errors, you can read through the case studies to see some different cases that were related to responsibility of errors. Where errors are made, they can occur in any setting: hospitals, clinics, pharmacies, doctor's office, and even patient's home. The ASHP has listed this common cause of medications list: ambiguous strength, designation on labels or in packaging, drug product nomenclature like look-alike, sound-alike drugs, use of lettered or numbered prefixes and suffixes in drug names, equipment failure or malfunction, bad handwriting, improper transcription, inaccurate dosage calculations, inadequately trained personnel, inappropriate abbreviations used in prescribing, label errors, excessive workload, lapse in individual performance, and the medication is available. Why errors occur? Error is human. We're not perfect. A person can look at the name and strength of a drug, yet fail to register the correct information, substituting unintended information in its place. The following are examples of errors in everyday life, and note whether they have happened to you. I'm sure that all of us have had one of these things happen to us at least once. Even the most highly skilled person can make errors. You know what you want to do, but your mind changes its focus and you follow the wrong information. That is automatic behavior. It plays a role in the occurrence of errors. In addition, when repetitive actions are carried out daily, it is easy to become complacent and lose focus on the task at hand. And in a pharmacy, that's exactly what we're doing pretty much every day. The following are examples of the daily obstructions encountered by pharmacy personnel: stress due to the fast-paced environment, an increase in the number of prescriptions processed daily, stress related to difficulties encountered during the insurance online adjudication process, noise in the workplace that distracts focus from the medication ordered, multitasking, doing 2 or more things at once, answering the phone, checking medications at the same time can distract attention from the order, medications that sound alike, medications that look similar, colors, shapes, sizes, or a similar area where they are stored, labels that look similar because of the same color and or lettering, labels that are difficult to read because of small print, prescriptions with illegible handwriting, excessive workload. Stress is going to be an issue in any job, right? It's in some capacity, whatever job you do, you're going to have stress. In pharmacy, shortages in personnel and increasing demand for services contribute to workplace stress. Eventually, that can lead to higher occurrences of errors and lower job satisfactions. Some stressors can include dealing with angry patients, rude healthcare personnel, high prescription volumes, employees calling in sick, and inadequate supplies or stock, and insurance processing complications. These affect everyone: the pharmacist, the pharmacy technician, the other pharmacy personnel, and of course, the patient. Open and honest communication should be used when discussing workplace stressors, and placing blame should be avoided. So just remember that you're working with the same people pretty much every day in a very small area. So it is very imperative that you get along with everybody and all try to deal with stress in the best way possible. Noise is typically a big thing that can cause errors. We have the telephones ringing nonstop, machines, intercoms, cell phones, and voices. However, and those are considered normal, but however, an overly noisy workplace can cause distractions affecting concentration at the task at hand, which could result in medication errors. Talking or laughing among employees during the prescription filling process can be disruptive and may seem uncaring or unprofessional to the customers or patients. The noise or vibration of a text message could also be equally distracting. And most organizations have restrictions on cell phone use and texting at work. We have this case study that you can read through and some follow-up questions just based on that paragraph. Multitasking can increase the chances of making mistakes and hinder problem solving and creativity. I'm just going to let you know right now that there's pretty much no way to avoid multitasking in the pharmacy, especially in retail. So you just have to do your best to try to do everything as accurately as possible and not take on too many tasks at once. Look-alike, sound-alike drugs, which you'll commonly see abbreviated as LASA. They look alike or sound alike. Those are big drug errors, risk for drug errors. We have the risk evaluation and mitigation strategies, which we call REMS. The decision to approve a new drug always includes the question, do the benefits outweigh the risk for the patient? Manufacturers and the FDA are continually evaluating these risks and benefits throughout the entire life cycle of a drug. Traditionally, these risks have been communicated via the package insert. However, in some cases, the FDA determines that the risks are significant enough to require additional product labeling to ensure patient safety. In these cases, a risk evaluation and mitigation strategy is recommended to ensure that benefits outweigh the risk. The implementation of REMS in the pharmacy workplace is unique to each practice setting. Pharmacists provide education to patients on the benefits and risks of the medications. Pharmacy technicians are involved with keeping lists of REM medications requiring med guides for dispensing and any medications that require REM components in addition to a med guide. Most of that will be taken care of by the pharmacist when they are checking the prescription. We have look-alike, sound-alike drugs, and so we use tall men lettering. So the ISMP and the Joint Commission, the TJC, promote the use of tall man lettering as one means of reducing confusion between similar drug names. Tall man lettering uses mixed case letters to draw attention to the dissimilarities in look-alike drug names as in the following. So these are look-alike, sound-alike drug names, and you can see why they have done that. So bupropion, buspirone, they have made the endings tall man so it sticks out compared to the other. This is another case study that you could read through. Drug labeling. Drug companies are urged to make changes in the labeling of any medication that can be confusing or misinterpreted. The use of color coding, tall man lettering, and boldface lettering can make drug selection errors less likely. Excuse me. Many pharmacists and pharmacy technicians believe that their excessive workloads are a threat to the public safety. the demands of processing hundreds of prescriptions in a 10 to 12-hour shift are increasing the risk of errors. Many pharmacy employees complain of few or no breaks, no time to eat lunch or dinner, and very little time to go to the bathroom when needed. Several state boards of pharmacy, such as Iowa and Oregon, are beginning to address the issue and develop strategies to combat these problems. In March of 2013, they came up with the following recommendations to prevent drug errors and patient safety is enforced. So require the pharmacy to provide sufficient personnel to prevent fatigue, distractions, or conditions that interfere with a pharmacist's ability to practice safely. Require the pharmacy to provide opportunities for rest periods and meal breaks. Require the pharmacy to provide adequate time for a pharmacist to complete professional duties and responsibilities. Prohibit introduction of external factors, productivity quotas, or programs such as time limits that interfere with the pharmacist's ability to provide appropriate professional services. Drug interactions are another source of errors in the pharmacy. The probability of drug-drug interactions is increased in seniors and severely ill patients because of the multiple medications they often receive. Seniors have multiple conditions that are treated concurrently, in addition to metabolism that occurs with age. Taking similar drugs that have the same side effects may increase the risk or the severity of adverse effects. Table 14.3 lists examples of drugs that should not be given concurrently. The drug spironolactone should not be given with angiotensin converting enzyme inhibitors that will result in increased serum potassium levels. The medication ciprofloxacin, an antibiotic, should not be taken with multivitamins with minerals. Decreased effect of ciprofloxacin because minerals and multivitamins can decrease antibiotic absorption if taken at the same time. So meaning if you're taking those vitamins and minerals, it's making your antibiotic work less effectively, which you obviously don't want if you have a bacterial infection somewhere. The medication digoxin and the medications verapamil and amiodarone, they can cause digoxin toxicity. Theophylline and quinolones can cause theophylline toxicity. Coumadin anticoagulants such as warfarin have the potential for many interactions with drugs, food, dietary, or herbal supplements. Certain warfarin interactions can be deadly. It is given to prevent clots that can cause strokes or heart attacks. The prothrombin time PT and the international normalized ratio INR must be maintained at a specific level to ensure that blood clots do not form and that the patient does not bleed internally. Regular blood tests are performed to check the PT INR level of patients that take warfarin. This table shows examples of interactions with drugs, supplements, and foods. Taking it with aspirin causes an increased risk of bleeding. Taking it with phentoin can cause an increased phentoin or warfarin levels, making either one of those drugs work more than it should be. Taking it with quinolones can cause an increased chance of bleeding, just as sulfa drugs can, cimetidine, heparin, amiodarone, and NSAIDs. So you see I have aspirin and NSAIDs highlighted. NSAIDs are like ibuprofen, Aleve, those things should not be taken at all. And obviously none of this should be taken at all, but you might commonly see patients in the retail industry picking up their prescription for warfarin and trying to buy either one of these over the counter. Supplements like ginkgo biloba can cause an increased chance of bleeding. Same with garlic. Decreased activity of warfarin can be caused by vitamin K, ginseng, and St. John's wort. Broccoli and other green vegetables or foods high in vitamin K can cause decreased effect of warfarin. Soybean and canola oils can cause altered effects of warfarin, and that is the same as cranberry juice. No one wants to make an error, but when it does happen, negative feelings and assumptions may emerge. For example, it may seem the person who made the mistake is careless, lazy, or untrained. Suspension or termination is a frightening event to consider. The reality that a patient suffered as a result of an error is horrible. Additional fears are the legal ramifications of lawsuits and possible public humiliation. All of these fears are in the back of our minds, along with the constant need to maintain the workflow. In a pharmacy, if we fill 1,000 prescriptions correctly and have one error, the pharmacy management will likely counsel the technicians and pharmacists to be more carefully, thus placing the blame on these employees specifically. This fear of being reprimanded adds to the stress on the pharmacy staff. Many times no action is taken to review the overall process of how the mistake occurred. Many pharmacy organizations and entities such as MedWatch, TJC, the Joint Commission, ISMP, and MERP, and others have recognized the need to study errors in a much different light. First, the need for opening error reporting without fear of retaliation is essential if the root causes of errors are to be revealed. Pharmacy staff members need to know that they will not be punished. Instead, the error will be examined and new strategies may be established that make it more difficult for errors to occur. It is important to have tools that can be used for error prevention. Even then, human factor errors will occur, but the goal is to reduce them as much as possible through the knowledge of how they occur. MedWatch and other error reporting agencies encourage reporting of all types of errors by both healthcare workers and the public. A MedWatch report can be accessed via the internet, which makes it a simple way to report an error. Errors related to patient care. We have healthcare associated affections, which are usually abbreviated as HAIs. They have plagued hospitals for decades. It is estimated that at any given time, 1 in 20 inpatients has an affection related to hospital care. Most of them involve urinary tract infections, surgical site infections, bloodstream infections, and pneumonia. All hospitals and other institutions have infection control specialists who are responsible for training both staff and patients as part of the investigation of all cases of healthcare associated infections. Home health care errors. Many patients are discharged home with instructions for self-administration of medications or with the help of visiting nurses. This is due to the rising costs associated with hospital stays. Receiving care in the home carries the risk of improper dosing and contamination of IV sets that may ultimately cause infections. Many elderly and disabled patients do not have coverage for infusion sets and supplies because Medicare only covers the cost of medication. Self-dosing errors can increase the risk of an adverse effect. Age-related errors. More people are living into their 80s and beyond. Life expectancy in the United States has risen from 49 years in 1900 to 79 years in the past century. By 2050, approximately 33% of the population will be over 55 and 20% will be over 65. Individuals over 80 will be the fastest growing segment of the population for the next 40 years. This is due to several reasons, including increased activity, better diets, and improved health care. Medication plays an important role in the longevity of people suffering from various conditions, such as osteoporosis, cardiovascular disease, and diabetes. It is estimated that nearly half of all Americans aged 55 or older take some type of prescription drugs, and about 40% take OTC medications. Many seniors mix medications on a daily basis, and as the number of medications increases, so does the possibility of drug-drug interactions. People tend to believe that any medication purchased over the counter is safe. This is a misconception, especially when these agents are mixed with prescription medication, and consideration also must be given to drug-food interactions. Most emergency department cases relating to pediatric patients and medication are due to overdosing of prescription and OTC medications. Most overdoses are primarily a result of failure to store medications in a secure area out of reach of children. Pictograms and the use of plain language have been shown to reduce the possibility of parents dosing their children inappropriately. Pictograms are standardized graphics, pictures that depict such things as how to take medication, how to store medication, and when to take medication. Many parents in the United States have problems reading and understanding dosage instructions because of low reading levels or poor understanding of the English language. Here are some examples of medication pictograms. Children and infants are also at an increased risk of drug errors in the hospital. Incorrect dosing is the most commonly reported error. Dosing errors include errors in dosage and dosing intervals. Children vary in weight, body surface, and organ system maturity. All of these factors affect their ability both to metabolize and to excrete medication. Medication errors that involve allergies. Some people are aware of the medications in which they're allergic to. Many allergic reactions can be avoided before drug administration. Allergic reactions are not always medication errors. However, many people can have an allergic reaction as a result of the physician failing to document or review the patient's allergies before prescribing medications. In one study of more than 50 patients hospitalized because of allergic reactions to medications, contributing factors to the allergic events were reported and included the following. The physician was not aware of the allergy, that was 41%. The physician did not believe the allergy was real, that's 5%. The physician was aware of the allergy but felt the benefit outweighed the risk, 4%. And the physician was not aware that the agent was in the same class of drugs, and that was 3%. Parental errors are the most frightening errors that can occur because they take effect quickly and cannot be easily reversed. This is the case with parenteral medications. Several cases of heparin and insulin overdoses have occurred. Heparin is of great concern because it is common to flush IV lines with Heplock solutions, which may be confused with similarly sized and labeled vials of much more concentrated heparin solutions. The clear advantage of sustained release medications, abbreviated as SR after the drug usually, is the ability of the patient to take his or her medication once daily rather than several times a day. This improves patient compliance and can ultimately result in better health. Directions that the dosage is in sustained release form are usually printed below the drug name on the manufacturer's label. If an SR medication is given in place of a regular dose, adverse effects can occur, including death. According to a report from the ISMP, suffixes such as LA, long-acting, CR, controlled release, CD, controlled dose, ER, extended release, XL, extended release, and SR, sustained release. They do not provide a clear meaning to indicate what that means in dosage frequency. The United States Pharmacopoeia defines two categories of modified release formulation: delayed release and extended release. Delayed release denotes a formulation that has coating to delay release of the drug until the product has passed through the stomach. Extended release denotes any formulation designed to deliver the dose over a longer interval than an IR, immediate release product of the same drug. Because of the confusion of suffixes, one form of the drug may be given in place of the other drug incorrectly. The necessity of reporting errors. So the pharmacist's daily routine. The pharmacists are usually overworked on a daily basis. Many pharmacies fill as many as 300 to 400 prescriptions. The workload also includes addressing discrepancies in orders, counseling patients. In addition, pharmacists must check the work of technicians. Excuse me. The limited time that a rush pharmacist has to check technicians' work adds to the potential for error. That's one thing I want to stop and kind of talk about. If a pharmacist has to continually fix and address your errors, that's not going to be good for your career. They have to check all of our stuff, but they count on us to be accurate, so they're not having to fix all of our mistakes. If they have to fix every mistake or a lot of mistakes we make or a lot of the things we do per day, why are we there? We're just causing them more work. So I always try to let you guys know how important it is to understand that you're their assistant. They depend on you to assist them with everything. They don't depend on having to do all your work with theirs, if that makes sense. Computerized prescription order entry. Many new systems are available that can help reduce error. So we abbreviate that as CPOE. The idea behind this is electronic ordering is that it circumvents having to decipher poor handwriting because orders are sent by computer directly to the pharmacy. So this kind of goes back into the e-scribing. It is becoming very popular for CPOEs in hospitals and other inpatient institutions, along with barcoding methods. Barcodes provide the following three forms of identification of a drug: the national drug code, lot number of the drug, and the expiration date of the drug. Reporting errors. The most important aspect of dealing with errors is the reporting process. In years past, the most common response to an error was to place blame on the person who caused it and then tell the person to be more careful. This type of response was found to be non-productive because most people will not report errors if they know they will be reprimanded. Also, trying to be more careful does not give the person the necessary tools to prevent further errors. Therefore, an emphasis on finding the causes of mistakes and ways to reduce those errors have been found to be more productive. So you're going to make mistakes, especially in the beginning. You should never hide them from your other technicians that are maybe more experienced or the pharmacist. You should go to them right away. Try not to let it bother you, even if at the moment they seem annoyed by having to fix something you did. It is way better for them to seem a little bit annoyed in the midst of a stressful day than for them to have to deal with you potentially causing harm to a patient. You're going to get constructive criticism in the pharmacy when you first start, especially, and it actually will last for a good amount of your career. You're going to constantly be learning new things. There's going to be new technology. So it's very important to be open to constructive criticism in this field. Organizations that track medication orders, we have the FDA MedWatch, the FDA Adverse Event Reporting System, the ISMP, the IOM, the National Coordinating Council for Medication Error Reporting and Prevention, the Joint Commission, the CDC, the United States Pharmacopoeia Medication Error Reporting System, and MedMarks. The ISMP tracks drug errors and works towards reducing them through MERP. MER can be accessed via the internet at that web address where healthcare workers can report errors, near errors, or hazardous conditions in the workplace. When reporting incidents, questions concerning how the error was discovered and recommendations for preventing recurrence of the drug are included in the report. The link to view an error report form you can see right here. Confusion over look-alike, sound-alike drugs or similar packaging can cause errors. Other specific incidents or errors to be reported are administering the wrong drug, dose, strength, route, or dosage form, or using the wrong route of administration, errors in dispensing, monitoring, performing, preparing, prescribing, and transcribing medications, and that MERP recommends the following: medication error understanding, improves the collection, classification, and analysis of data linked to types, causes, and sources of error, and the impact of errors on patient, tracking medication orders in a systemic manner, and prioritizing reduction activities are also included. Medication error reporting increases awareness of reporting systems available, such as MERP, MedMarks, and MedWatch. These programs maintain a classification system that identifies different types of errors. The data obtained can then be used to analyze and report error statistics. Medication error prevention with continuous research and reporting. Areas can be identified where changes can be made to prevent future errors. Reporting can be done anonymously and voluntarily without fear of retribution. The MERP reviews all medication error reports, attempts to understand the reasons for errors, and works toward producing initiatives to educate healthcare workers and improve med safety. The following 5 guidelines are used to share information with healthcare professionals about potentially dangerous events. Number 1, knowledge. Number 2, analysis. Number 3, education. 4, cooperation. 5, communication. In 2012, the ISMP launched the National Vaccine Error Reporting Program to capture the unique causes and consequences of vaccine-related errors. The TJC is another organization that helps institutions implement safety standards to reduce errors. TJC's 5 areas, each having 10 criteria for ensuring patient safety, are summarized as follows. Number 1, leadership, process, and accountability. Number 2, competent and capable workforce. Number 3, safe environment for staff and patients. 4, clinical care for patients. 5, improving quality and safety. A primarily responsibility of TJC is to review documentation that tracks progress in each of these areas. Strategies for reducing errors. As we have learned, many factors contribute to medication errors. Each pharmacy should develop a system designed to strengthen its medication management practices and help reduce the number of preventable medication errors. The ISMP has launched the 2014 to 15 Targeted Medication Safety Practices for hospitals to help identify and reduce medication errors that recur despite repeated warnings. These practices provide strategies for error prevention and target a group of 6 key safety issues. The ISMP's targeted medication safety practices for hospitals are as follows. 1. Dispense vincristine and other vinca alkaloids in a mini bag of a compatible solution and not in a syringe. 2. Use a weekly dosage regimen default for oral methotrexate. If the prescription is changed to a daily regimen, use a hard stop verification of an appropriate cancer indication. Provide patient education by a pharmacist for all weekly oral methotrexate discharge orders. 3. Measure and express patient weights in metric units only. Ensure that scales used for weighing patients are set and measure only in metric units. 4. Ensure that all oral liquids that are not commercially available as unit dose are dispensed by the pharmacy in an oral syringe. 5. Purchase oral liquid dosing devices such as syringes, cups, and droppers that display only the metric scale. 6. Eliminate glacial acetic acid from all areas of the hospital. Barcodes provide the following 3 forms of identification of the drug. We've kind of just talked about that. The NDC, the lot number, and the expiration date of the drug. We now have robot RX machines. Large robotic machines have been used for many years in some hospitals. Patient medication records are read by the machine through the use of barcoding. The appropriate medication's barcode is scanned from the package and then matched to the electronic medication administration record, the EMR. Once the barcode has been verified, the machine pulls from a rack of prepackaged unit dose medications stored in the unit. The medications are placed in a patient envelope and are delivered to the appropriate floor. These large fillers are expensive and require a large area for functioning. Automated dispensing machines have been used for years in hospitals and institutions. They store unit dose medication and nursing supplies to be accessed by nurses on patient floors. The pharmacy receives an order and enters it into the ADS computer, which then allows the nurse to access the medication using the patient's name. These systems work effectively if the medication in the drawer is correct. If the wrong medication is loaded into the drawer and the nurse fails to catch the mistake, an error can occur. However, coupling this system with barcoding greatly reduces the risk of errors. Each cubicle has an attached barcode that identifies the medication. When the technician attempts to fill the cubicle, he or she must match the barcode on the cubicle to the barcode on the medication. The nurse can use the barcode to match the drug to the patient. And another type of automated dispensing machine is the med carousel. The med carousel is a vertical automated storage and retrieval system for medications in hospital pharmacies. Community pharmacies also have automated dispensing machines, tabletop automatic pill counters. These devices are used for counting and verifying every order. The device's touchscreen displays a picture of the medication and specific information about the drug. You can see that there. Large wall units that use cassettes, such as Baker cell systems. The number of cassettes is limited only by the wall space available, and each cassette holds an assortment of preloaded medications. Robot technology. The system is a fully automated robotic prescription dispensing system. It accepts prescription dispensing instructions from pharmacy computers and delivers filled and labeled vials at a rate of up to 100 per hour. I did work with a system, definitely not as nice as this, way older, but it essentially did the same thing. It didn't do 100 prescriptions, it just did 10. But the amount of time that it saved for the medications that were in the robot, nothing can compare to that. I worked in a very busy pharmacy where we did sometimes 700 to 1,000 prescriptions a day. I honestly don't know how we would have kept up without it. Patient-specific dose orders for the hospital. That is what we're always going to do. When patients require a large amount of liquids over a 24-hour period, a bulk bottle of liquid is placed in the patient's drawer. Also, if the liquid was not available in unit dose form, it was sent in bulk form. This was in the past. The nurse poured the proper amount per the MAR and used the liquid until the bottle was empty. The nurse then sent a refill request to the pharmacy. The bottles were sometimes labeled with just the patient's name and room number. Because specific dosing instructions were not noted on the bottle, there was an increased likelihood that the nurse might dose the liquid medication inappropriately. Also, opening and closing lids can increase the risk of contamination of a medication. The pharmacy must have control over each dose to ensure accuracy. The TJC requires hospitals and institutions to pre-package all liquid doses in an oral syringe or container. Each dose is prepared by the technician and is labeled with the patient's name, medical record number, and room number. In addition, the name of the dose, drug strength, and time of administration are indicated on each dose. In this way, each dose is strictly controlled by the pharmacy. Automatic robots can also fill and label doses, reducing the time needed by a technician to fill the daily. The United States Pharmacopoeia 797 regulations. One of the regulations established by them addresses the problem of contamination of any type of sterile product. The adoption of USP 797 has been one of the most dramatic changes for any pharmacy that prepares sterile products, such as IVs and other parenteral medications. Because of the new regulations, many pharmacies are contracting their sterile preparations to companies that specialize in this area and have met all guidelines of USP 797. In Chapter 12, you can read more about USP 797 regulations. Medication safety is the responsibility of all pharmacy personnel. For any safety system to succeed, there must be an effective leader at the helm. ASHP has identified this role as the medication safety leader. This person is most often a pharmacist and is looked to as an expert on safe medication use. The medication safety leader usually reports to the risk management department or senior administrator, and these individuals lead the team in developing strategies for reducing errors. To reduce errors, pharmacists can do the following: check prescriptions carefully and thoroughly, initial check prescriptions, document all clarifications made to any orders, visually check the product in the bottle, counsel all patients with new prescriptions, and report all errors or adverse events. To reduce errors, the pharmacy technicians can do the following: refer any questions regarding bad handwriting or ambiguous orders to the pharmacist immediately, triple count controlled substances, double check dosage calculations with the pharmacist, keep the work area free of clutter. I'm going to stop there and talk about something in the retail world. When you go to, if you're at the fill station and you think to yourself, I'm really busy, so I'm not going to go put away any of the drugs I just used. So next thing you know, you have 20 drugs on the counter. You're filling, whatever. Then another technician comes in and starts helping you fill. They start going to the shelf looking for medications, not realizing that they're on the counter, and then they are marking them out of stock in the system. So meaning when the patient comes to pick up the medication, someone at the drive-through or counter is telling them, we're out of stock of your medication. We have to order it. It'll be here tomorrow. Even though it's only tomorrow, the patient's probably not going to be that happy. And we have it sitting on the counter. So it is always important to, after you fill a medication, immediately return it back to stock. Do not have a buildup of meds. Do not say to yourself, I'm going to have 10 bottles here and then I'll go put them away. Immediately put them away. That is one thing I stress to externs when I was a senior technician in the retail world. One thing I stress to my coworkers, new coworkers, it is very easy to make a drug error by doing that. You can grab the wrong medication. Lots of things can occur. Always keep the prescription and the label together during the filling process. Check the drug 3 times when removing the medication from the stock bottle, after placing the medication in the prescription bottle, and before returning the medication bottle to stock. Observe and report to the pharmacist any pertinent OTC purchases made by patients. To reduce errors, pharmacies can do the following: use automated filling systems, scan the original prescription, use electronic prescribing, keep high alert medications in a separate location in the pharmacy, maintain accurate, up-to-date patient profiles that include OTC and herbal medications, designate a medication safety leader, continually review safety policies and procedures, especially with new staff members, encourage error reporting by employees, focusing on change, not punishment. Medication reconciliation. So this is another strategy to prevent patient harm. Strong reconciliation practices can play an important role in the reduction of medication-related errors. The Institute for Healthcare Improvement, the IHI, has defined medication reconciliation as the process of identifying the most up-to-date list of the medication a patient is currently taking. The IHI reported that more than 50% of all errors in hospitals are due to poor communication of medication orders. The necessary information required to clearly analyze a patient's need includes the following: the name of the drug, the dosage, the frequency, and the route of administration. Reconciliation needs to be performed in all pharmacy settings, although each type of pharmacy must develop its own specific strategies. In institutional settings, it is important to compare the current list of medications with the list shown at the time of admission, at the time of any transfer within a facility, after surgeries, and at the time of discharge. The goal is to ensure that the patient is given the proper medications at all points as he or she moves through the healthcare system. In this way, any errors can be identified promptly. These steps involved in completing a medication reconciliation are in this procedure. I actually was a medication reconciliation technician for about 2 years at my local hospital's emergency department. Very rewarding job. You have to know a lot about medications, so it's definitely not a job for a new technician. But it is very rewarding. You're constantly helping patients. You feel very much connected with the other healthcare world, like differently than you would in the retail or even the inpatient setting. So you would have a medication reconciliation form. First, you would use verification. You would obtain the patient's medication history and other medical information. This includes all medications, OTC products, and herbal remedies. So we would go into the patient's room, ask them if they had a med list. We would then use that med list to compare what we already have on file if we had stuff. And then we had a system that we could go to and check all the medications they filled at pharmacies in however time span. So we had 3 different ways to check to make sure. A lot of patients don't update their personal medication list. So sometimes they'll think they're taking one strength of a medication, but when we pulled their information from the system we use, which was called like Dr. First or something like that, they were taking a different milligram. So even just small things like that can have such an effect on medication given in the hospital. Clarification, we need to make sure the medications and dosages are appropriate for the patient. Just as I was saying, we're comparing the physician orders to the med list of the patient. Then we would reconcile. Clinical decisions are made based on the comparison between the 2 drug lists. Resolving any observed discrepancies or errors through documentation and direct communication is the final step. This includes several parties: the patient, physician, nurse, and pharmacist. If you go to a new doctor, in fact, if you go to your doctor's office anytime, they're going to ask you what medications you take. This is going to be done by several different people, but the act of actual medication reconciliation completed by pharmacy technicians and pharmacists, and that role is much different. We're actually doing research, calling around to pharmacies, calling insurance companies, doing everything we can to ensure that we have the right dose for the patient. Quality assurance practices and risk management. So to prevent errors, we should use the following quality assurance measurements. Avoid or question abbreviations that are uncommon or on the do not use list. Double count narcotics. Inspect fire extinguisher and fire and first aid kits. Keep areas specific to the task. For example, prescriptions already verified by the pharmacist as ready should be separated from the prescriptions to be prepared or filled. Keep the prescription bulk bottle and filled bottle together for verification. So like I was saying, return to the shelf. Some pharmacies need you to keep the bottle until you goes to the pharmacist. Pharmacies with higher technology, usually the pharmacist can see what it looks like on the screen and they can compare that to the actual drug. Use a leading zero. We never want to put 0.5. We want to put 0.5. Use different storage and or shelving and post warning signs for LSA, LASA, or special medications. Use barcodes, write legibly and neatly. In addition to good practices, there are the reporting systems that we've already talked about that can report and track and alert for errors in an effort to prevent future occurrences. Other considerations, so we should always make sure that we use good lighting to clearly read the label and check the drug against the prescription. Also, filling protocol systems must be reviewed and altered if they can potentially cause an error. Reducing the fear of anxiety of reporting errors should be implemented in all medication safety or all medication settings, and each prescription should be checked several times to ensure that it is correct. One of the best ways to reduce error is through training and education. Many states do not have standardized exams or use the national exam to pre-test technicians. Some states do not even fingerprint or conduct a background check on pharmacy technicians. This has actually changed quite a bit since the book was written. Many schools with pharmacy technician programs are not accredited and do not have standards of learning. Many large pharmacies train their own employees to become technicians. The Pharmacy Technician Certification Board, the PTCB, and the ASHP have worked towards implementing training standards in organizations such as the Society for the Education of Pharmacy Technicians. They promote education and training before and after certification. So at the end of this program, you will take the PTCB exam to become nationally certified. Beyond certification and continuous training, technicians should always check prescriptions 3 times throughout the filling process. If anything about the prescription seems unclear or confusing, the pharmacist should be notified immediately. Remember, the pharmacist is there for just like you're their assistant, you should be able to go to them about anything you don't feel comfortable with or anything you have questions. So then again, we have the methods for avoiding errors in the pharmacy. We've talked about all of these several times. And then do you remember these key points?